So revisiting this diagram of the capillary bed, once again, we can see the major components of the capillary bed. So we've got our thoroughfare channel. We've got things called metarterioles, and these are the ones that have the capillary sphincters and the precapillary sphincters. They're going to control the blood flow into the capillaries. So they're going to be the ultimate determining factor in the perfusion of the capillaries. We also sometimes will have these arteriovenous anastomoses, which are direct bypasses that go from the arteriole to the venule. And so if we look at this, we've seen one of these pictures before from a different textbook. And here we have a small artery perfusing an arteriole, which will then perfuse these metarterioles that are going to be regulating the blood flow into the capillary beds, which are smaller still. And as we've said, we've seen the thoroughfare channel, and that's basically direct capillary connections between the arterioles and the venules. And we also have, surrounding the capillary beds, we have our metarterioles that are actually part of the capillary bed. They are going to be regulating the amount of blood into the capillaries themselves. Sometimes we have what are called collaterals, and these are blood vessels merging in that can perfuse the same capillary bed. And these are very important because these are like an insurance policy. This is your alternate route in case one route gets blocked. And when you think of high value real estate like the brain, the heart, you want to protect these tissues at all costs because these are central to homeostasis and maintaining function. So a lot of times there are going to be these anastomoses, especially arterial anastomoses, which are basically where we have two arteries that are going to feed the same bunch of vessels. So a lot of times when we study the brain, for example, we'll see some arteries that form what's called the circle of Willis at the base of the brain, so that if any one of those arteries get blocked, you have almost like a traffic circle there. You have a way to go around that artery that was blocked and perhaps perfuse the same tissue via another artery. And we'll talk about arterial anastomoses. We see them in the heart as well. And this is basically, once again, just an alternate route that allows as sort of an insurance policy in case one route gets blocked, then you have another one that may be able to perfuse the same tissue so that you don't have any serious damage from hypoxia or lack of perfusion. Then we also have arteriovenous anastomoses, and these are direct connections between arterioles and venules. And these basically will be a direct bypass of the capillary bed. Now, as we've said before, we do not have enough blood to perfuse every capillary in the body. If all the capillaries were open all at once, the blood would all be in the capillaries. We could not have enough pressure to perfuse the circuit. If all these, we would have such a large cross-sectional area that our pressures would drop precipitously within the capillaries. So we have something called vasomotion, and that is where we have these precapillary sphincters that are relaxing and contracting in cyclic sort of alternation. And that allows for part of the capillary bed to be perfused at one moment and another part of the capillary bed to be perfused at another moment, and so forth. So all the tissues are getting perfused, but are getting kind of perfused in this cyclic manner. And as we have seen, we have these arterial anastomoses here, and these arterial anastomoses allow for merging of blood vessels. A lot of times, if a tissue becomes very hypoxic due to one blood vessel getting blocked, sometimes you can have an outgrowth of more blood vessels from existing blood vessels, and this is called angiogenesis. And angiogenesis is the formation of new blood vessels. And a lot of times, obviously, we see this in development, but we can also see this in tissues where they're getting a little bit hypoxic because one of the major arteries is being occluded. And this is especially true, for example, coronary arteries. If they start to get occluded, they might start sending out these new outgrowths of vessels that may form anastomoses, and you may have this angiogenesis, which allows for the formation of new vessels to bypass naturally the circuit that's being blocked. And there is a growth factor called vascular endothelial growth factor that is responsible for this. In the common circles, this is referred to as VEGF. Now, VEGF is also at the forefront of research right now for two reasons, and that it is not only important for regenerating vasculature after some kind of insult or infarct, or when there's some sort of, say, coronary artery disease, but also it's implicated in cancer, because what cancer likes to do is hijack the body's natural mechanisms, and cancer cells will often promote angiogenesis to bring large networks of blood vasculature into the cancer, because the cancer is consuming lots of nutrients, lots of sugar, lots of oxygen, and so forth. So it's going to create this massive perfusion of the cancerous tissue. So it often will create angiogenesis. And so stopping angiogenesis or preventing angiogenesis in cancer cells is also a big area of research. Now let's look at the veins. So veins, as we've seen, are going to collect up the deoxygenated blood and take it back to the heart. And so obviously from the capillary bed to the venule to the medium veins, the large veins, and so forth, then as we've seen, we've got this progression of veins back to the heart. And as we remember, the large veins are going to be the ones that are going to feed into the superior and inferior vena cava. These are the ones that are going to have valves. These are going to be the ones that, especially in the lower extremities and legs, are going to be reliant upon the action of muscular contraction to help move blood uphill, so to speak, and act kind of as a pump. And we've also seen the respiratory pump that also helps move blood back into the thoracic cavity from the lower extremities against very low pressures. Because remember, the pressures at this point are 18 millimeters of mercury or less, because at the end of the capillary bed, we've got about 18 millimeters of mercury. And then by the time we get to the right atrium, we're down to very near zero. Now let's look at the distribution of blood in the body. So we're going to have about 30 to 35% of blood will be within the heart, the arteries, and the capillaries, and the rest will be in the venous system. And about 1/3 of that is going to be in the liver, the bone marrow, and the skin. We'll also see that the spleen has a large reserve of blood as well. So here's just the overall general distribution, and we can see the systemic venous system here. And this means in the systemic circulation, we have about 64% of our blood is in there at any given time. And then we can see our pulmonary circuit, about how much blood is in the pulmonary circuit at any given time, how much blood is in the heart at any given time, how much blood is in any given arteries at any time, and then the systemic capillaries at any given time. So you can see that a large portion of blood is hanging out in the venous system. And this is what we were talking about, that fact that the veins are what we call compliance vessels. They're also called capacitance vessels because they can change their capacity, and they can stretch quite a bit more than arteries because of the very fact that their luminal diameters are usually fairly flat, because there's usually very little pressure in the veins. So we can have something called venous venoconstriction, and that is going to allow for the venous circuit then to constrict and increase peripheral resistance. And this will happen, for example, when you have very low blood volumes, or when you have very low, for example, due to trauma, you're losing blood. And so the blood vessels, as we say, are called capacitance vessels, also called compliance vessels, because they can change shape very readily depending on the amount or the volume of blood that is in them. Now, when we look at the flow of blood through the capillaries, we will see that the capillary blood flow is going to equal the cardiac output, which is going to be determined by the pressure and the resistance in the cardiovascular system. So as we've said, these two things are sort of counter to one another. So there's pressure, and then there's resistance. So we have to generate pressure in order to overcome resistance. And that resistance can be in the form of anything, like gravity, like friction, due to the blood vessel walls. So as we've seen, we have a pressure gradient from the artery through the capillary to the vein. And we've seen that that pressure gradient is going to be what is responsible for moving blood. Blood really is going to go down its pressure gradient, just like water goes downhill. And so we're going to see that we've got this very high pressures at the aorta of say, mean arterial pressures of 100 millimeters of mercury. And then by the time we reach the capillary bed, at one end of the capillary bed, at the arteriole end, we're about 35 millimeters of mercury. By the venule end, we're at 18 millimeters of mercury, somewhere in that vicinity. And then that pressure will continue to drop all the way to the right atrium. And so this is what's going to cause the blood to flow down its pressure gradient. And flow is basically the movement of blood. So it's going to be proportional to the difference between this difference in pressure from one end of the circuit to the other end of the circuit. So basically, the flow is going to be inversely proportional to the resistance. The more resistance we have to flow, then the less flow we're going to have. So let's have a look. So we've got blood pressure, which is our arterial pressure in millimeters of mercury. We've got our capillary hydrostatic pressure, which we've seen, which is the pressure within the capillary beds themselves. And that's what's going to be forcing blood through the capillaries. And remember, it's also what's going to be driving certain solutes out of the capillary beds through filtration. And then we're going to have the venous pressure, which is in the venous system. That starts around 18 millimeters of mercury and goes almost to zero. But when we look at the entire circulatory pressure, the change in pressure across the entire circulatory system, then this is what's going to determine how blood flows. And imagine that you didn't have a very high pressure gradient. And let's say your blood pressure drops. Let's say it drops to 80/45. Now you might have a problem because you might not have enough pressure to perfuse the entire systemic circuit. You may not have enough pressure to overcome the peripheral resistance. And so the resistance of the entire cardiovascular system is the resistance to blood flow of the collective of blood vessels. So we have vascular resistance, and that's going to have to do with the friction of the blood vessels, of the blood vessel walls, of the blood flowing through the blood vessels and how they interact with the blood vessel walls. We're also going to see that blood viscosity plays a part. So if you have lots of formed elements in blood, if you have high plasma proteins and your blood viscosity is thick and syrupy, that's also going to make it harder to push through the blood vessels. In fact, people who do blood doping, where they pull out some of their blood and then re-inject it later on for the formed elements such as erythrocytes, or if they take erythropoietin and they don't need it, and they create lots of red blood cells, they think they're going to improve their athletic performance because they think they're going to be able to carry more oxygen. Well, they're also creating higher blood viscosity. They're creating more resistance to flow because the thickness of the blood typically is about 5 times thicker than water anyway. So if you create this increasing thickness of the blood and you make it more and more syrupy, then your heart has to work harder to overcome this increased resistance due to the thickness of blood. So in that case, a lot of times people who have mismanaged their blood doping will end up sometimes dying from heart attacks and other things because their heart has to work so hard it cannot overcome the extra resistance from these extra blood viscosity. Then we have something called turbulence. And we've already talked about what turbulence is. And think about a river. And you have a calm, still river moving in a wide river where the banks are far apart. The flow usually is quite still. It's pretty what we call laminar. So basically it moves without any kind of turbulence or resistance, kind of like rapids. So think of turbulence like rapids in a river. And turbulence can cause these eddy currents and swirls and all of these kinds of things. We've already seen some things that can cause turbulence, blockages, plaques, these kinds of things. And these can also increase resistance to blood flow. So here we have some factors that will affect vascular resistance. One is length. And the length of the blood vessel is going to increase proportionally, or I should say the resistance is going to increase proportionally with the length of the blood vessel. So for example, if you have a blood vessel that has an internal surface area of 1 and the resistance to flow is 1, and then we increase that internal surface area to 2, then the flow reduces to 1/2. So basically by a factor of 2. Secondly, we have another thing to consider is that by the time we reach our adult size, this is not going to change. The length of our blood vessels really aren't going to change. Yes, you might have some angiogenesis. You might create a few more blood vessels, but typically no. This is not going to change in adulthood. What does change is the blood vessel diameter. Now, what we will see is at the center of a blood vessel, we have the least resistance to flow because we're farthest from the walls and we're not generating friction. And so what we will see then is that blood can flow more freely through the center, just like at a river. If you've been in a river, especially one that's pretty fast moving, and you go to the center, you've got these fast moving currents in the center. And then as you get closer to the bank, the water tends to kind of hug the bank and it's slowed down a little bit. And this is where you'll see swirls and eddy currents. So one of the things we will see is the main determining factor that's going to create the most resistance in the body is going to be changing the blood vessel diameter. And when you change the blood vessel diameter, you are exponentially, by a factor of 4, going to increase the resistance as you decrease the blood vessel diameter. So for example, if you have a blood vessel diameter that's 2 centimeters and you decrease that diameter to 1 centimeter, you are going to increase the resistance to flow 16 times. So this is an example of where we can see even very small changes in blood vessel diameter are going to create the largest changes in peripheral resistance. So this is why blood vessel diameter is the determining factor when we look at blood pressure and when we look at peripheral resistance. And so a lot of times when you look at blood pressure medications, what do? A lot of them seek to increase the blood vessel diameter, to relax the blood vessel diameter. Another thing that blood pressure medications do often is trying to change the cardiac output to lower it so that you have less volume within the circuit at any given time. Now let's look at the way the blood flows through the systemic circuit. So we're going to see a large vessel diameters give way to smaller and smaller and smaller vessel diameters, but then our total cross-sectional area will increase exponentially, because we will see that although we have very few large vessels that have diameters of 2.5 centimeters, for example, the aorta has a diameter of about 2.5 centimeters, but it's only one vessel. And so it has what you would think to be a fairly low resistance. It is then feeding into blood vessels that have higher resistances because they have smaller areas. However, as these blood vessels diverge from the aorta, they have very large total cross-sectional areas because there are many of them. And so it's like a large river feeding into smaller rivers, feeding into ever smaller tributaries and so forth, until you have hundreds of thousands of little rivulets that are, if you were to take the cross-sectional area of the water that's flowing through those little rivulets and add it all up, it would be much greater, exponentially greater than the volume of water in the main river. And this is exactly what we see in the cardiovascular system, where we have one large vessel, the great vessel, the aorta, that's about 2.5 centimeters in diameter, and it's going to give rise to multiple smaller vessels that are going to get narrower and narrower and narrower. But for each branch of an artery off of the aorta, you're going to see those arteries branch, and then those arteries branch, and those arteries branch, and so that you're going to see this tremendous increase in the cross-sectional areas. The pressures are going to decrease, as is the velocity of the blood flow. So here we have an example. Here we have our blood vessel diameters. We can see the aorta is the largest, and when we look at the individual arteries, they're going to get smaller and smaller and smaller until we get to the capillaries, which are the absolute tiniest. Remember, capillaries are perfusing all the tissues, so we have hundreds of thousands, if not millions of them. And so then that's going to then feed into venules that will then feed into ever larger increasing veins. And remember, our veins are larger and have larger areas than the arteries. And of course, we're going to see pressures in this part of the circulation is going to be extremely low. So when we look at the total cross-sectional area, we can see that we have 2.5 centimeter diameter for your aorta, but as the arteries branch and continue to branch into arterioles and then capillaries, the total cross-sectional area of the blood vessels is huge. And so this is why we will see a decrease in blood pressure. We will see a decrease in resistance as we get through here. And then, of course, we have these capillaries feeding back into venule veins and then eventually into the vena cava. Now, when we look at the blood pressure is greatest at the aorta and is going to be the least at the right atrium. So we have a continuous descent in blood pressure. And so that makes our difference in our blood pressure gradient. That's what causes the blood pressure gradient, is the difference at the great vessels compared to the right atrium when all the blood, the deoxygenated blood, is returned. Then we can look at the velocity of blood flow. Not surprisingly, the velocity is fastest as we look in the larger vessels, and then it's going to slow tremendously as it goes into the smaller arteries with these much, much smaller diameters. But remember, the total cross-sectional area is huge, so it's exponentially greater than what we would see at the opening of the great vessel as it leaves the heart. So the rest of the stuff we covered a lot in lab. We talked about the systolic pressures, the diastolic pressure. So the systolic pressure is the peak pressure during ventricular systole, and the diastolic pressure is the minimum arterial pressure during diastole when the heart is relaxed. The pulse pressure is the difference between them. As we've seen in lab, the quick and easy way to calculate the mean arterial pressure, which we see is really that difference closer to the heart end. Because remember, this pressure pulse that we're going to see, remember the difference between the systolic and diastolic is the pulse pressure. The pulse pressure is going to be decreasing as we go further and further away from the heart. So our mean arterial pressure, basically, we can take 1/3 of the pulse pressure and add it back to the diastolic pressure. And that kind of gives us our mean arterial pressure that we can think of as being the pressure near these large veins, such as the brachial vein, where we measure blood pressure. All right, so we talk about normal blood pressure. Normal is about 120/80. Now, of course, the American Heart Association is always changing these guidelines, but when this book was written, it was 120/80. Some guidelines are saying, no, it really should set the floor at 70, so basically diastolic should be 70, but there is some debate, and that is a continuing discussion going on within the medical community. Hypertension is typically considered above 140/90. Then hypotension is when you have abnormally low blood pressure. This is problematic because this can lead to lack of perfusion to the tissues, especially the brain. And people who have chronic hypotension will sometimes just pass out simply because they're not getting enough blood to the brain. And also over time, this can lead to problems because over time the tissue is starved of oxygen, so you get this sort of chronic low-grade hypoxia. And so this is the rarer of the two. You usually see hypertension rather than hypotension. But hypotension can also result when you give people very strong blood pressure medications. Sometimes you can go too far in the opposite direction, and the patient can have hypotension and they're not perfusing their circuit properly. So as we've seen, the arterial walls have an elastic rebound. That's because they are elastic vessels. And this is what gives rise basically to our pulse pressure. And it's also, remember, one of the things that's going to help perfuse the coronary vessels. Because as you recall, when the aorta, when the left ventricle pumps blood through the aortic valve into the aorta, not only does the pressure decrease in the ventricle suddenly as it relaxes, and you have this elastic recoil of the blood vessel, but the aortic valve is going to close. And this elastic recoil is going to force blood back to the ventricle, but instead of entering the ventricle, it will enter the coronary circulation because those coronary blood vessels will come right off the aorta right after the aortic valve. So this is an important thing. Elastic rebound is important for this. And this also, not only is the elastic rebound important for perfusing the coronary circuit, but it's also important for keeping the blood moving through the circuit when the ventricle is relaxed, when there's diastole, and when there's no pressure, no force moving the blood through the circuit due to the action of the heart. So we've already talked a little bit about all of this in lab. So here was the diagram that we showed. So near the heart, where we have our large vessels like the aorta and the vessels that branch off of it, we can very easily see the pulse pressure. And the pulse pressure is the difference between the systolic and the diastolic. As we have moved more into the muscular arteries and the arterioles, this pulse pressure falls off. And so it's more evened out. And as we noted, the book likes to compare this to an echo, where you shout out something in a large canyon and you hear the echo, 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 but as it goes farther and farther away, you just hear one sound. So that's kind of what happens with our pulse pressure. It falls off the further away from the heart that we get. But what we're measuring at the brachial artery is somewhere up in here. So our mean arterial pressure should be somewhere around 90 to 100, typically in people where we're measuring blood pressure. Now, of course, you can also measure blood pressure. There are wrist cuffs for blood pressure and there are ankle cuffs for blood pressure, but typically we put the sigmometer right here on the brachial artery, as we saw in lab. So that just sort of points out once again the difference between the systolic and diastolic is easily measured close to the heart as this pulse pressure. And once again, our mean arterial pressure, the quick and easy way to figure out the mean arterial pressure is to take 1/3 of the pulse pressure and add it back to the diastolic, and that gives you your mean arterial pressure, or a good approximation of it. All right, so as we've seen, we've talked about most of this before. We've talked about pressure and venous return and the fact that the pressure drops off markedly in the venous system. So we have these two things. We've got our valves in our large veins that are going to prevent backflow with gravity pulling blood back down to the legs where it would pool there. So we have valves. We have the action of the muscles, the skeletal muscles that act as kind of a pump to keep the venous blood moving upwards. And we also have the respiratory pump, which is simply when we breathe in, and that's going to first increase the pressure in the chest, and then we decrease the pressure in the chest, and the blood will want to rise towards the chest when the pressure within it has decreased.